Hello everyone, my name is Flóra, Olasz, and my PhD topic is complex therapy for children with cleft lip and palate. Before I dive into my topic a bit further, let me introduce myself first. I'm a third-year orthodontist resident at the Department of Pediatric Dentistry and Orthodontist. My supervisors are Noemi and Lily, and my SMS is Bianca. With my amazing clinical team, we are trying to understand the complexity and the cleft's origin and care by researching different etiology factors and treatment possibilities. Obviously, there's multiple ways to see and to research cleft, but it's important to start from the beginning as we see it, which leads to my first topic, which was investigating the effectiveness of presurgical therapy possibilities for unilateral cleft lip and palate in infants, which is a systematic review and meta-analysis. I'm sure at one point most of us or some of us want to have children, and we want to have happy and healthy children, but little do we know that cleft lip and palate is one of the most common congenital anomalies affecting the craniofacial region. Out of 800 babies, 1 is born with this anomaly. We know some of the etiology factors can be genetic or environmental, and we also know that there is a difference between the frequencies of the cases when it comes to different countries and continents. The malformation itself occurs in the 5 to 12 weeks of the utero when we have palatal shafts that get disturbed in diffusion. Why is it important to talk about it? Why is it important to research it? Obviously, babies born with this anomaly have a hard time or trouble breathing, swallowing in the beginning, even with feeding, and later when it comes to speaking or hearing, they have a high defect, as well as impossible amount of dental possibilities that have trouble, such as crossbite or different development in the maxilla particularly. This is where our role comes in as orthodontists. Before we have a cleft closing surgery at 5 months, we can help them throughout this period for this 3 to 5 months with a therapy possibility, which is called a presurgical nasoalveolar molding. As you can see in the upper right, this is an acrylic plate. We place it into the baby's mouth. This way, as you can imagine, the gap is closed between the nasal and the oral cavity. So it doesn't just help somehow with the functions, it also helps to improve the maxilla anatomy as well, because it stays there for 24/7, only removed once a day to clean. And we see these babies every 2 to 3 weeks, where we make some differences in the appliance. Therefore, we can help the bone grow into a specific way to narrow this gap that you can see. On the lower left, you can see there's different points picked out on the maxilla. It's important to have the molding observed in the beginning and just before surgery to see how much we improve the maxilla itself. This leads us to our clinical question, which is how efficient is prompt treatment in unilateral cleft lip and palate? Our populations were infants with UCLP. Our intervention group was babies treated with this treatment, and our comparator was no treatment. And our outcome that we looked into mostly was cleft shrinkage. Our hypothesis is that PNUM treatment is more efficient than no PNUM treatment in infants with UCLP. Our clinical and research implication is using PNUM treatment leads to guided alveolar growth that results in cleft shrinkage. We researched 3 different databases that led us to almost 500 articles. As you can see, this is not a highly research topic, so it's very difficult to find relative articles, but we ended up with 5 in the end, which we could pull results from. Before I get into my figures, I'd like to explain a bit further how we looked into our outcomes. On the right, you can see a healthy baby with a healthy maxilla, and on the left, you can see a cleft baby. As you can see, there's a massive gap between the nasal and the oral cavities, and just here you can see how we close it with cleft surgery. Obviously, I think with common sense, we can all see that closing a smaller gap is way easier than closing a larger gap. Therefore, our aim is to make sure that these segments get closer to each other through time. And we achieve that with our different appliances to help them grow into a specific way. Therefore, we have 3 different outcomes. First, where we looked into anterior cleft width, we also looked into intercanine region width and posterior arch width. Starting with my very first figure, as you can see, this is the anterior cleft width. Why we were expecting more results here is because basically this is only the alveolar bone part of the maxilla, this is the one that can be manipulated the most into a specific bone growth way that we want it to be. So we had really high hopes with this. As you can see, we looked into 5 different RCTs with our quite a large sample size. We did have high heterogeneity. And when we compared the treatment versus no treatment group, we can see that overall in time, we could see a shrinkage between these two groups, which favored our treatment group. This is statistically not relevant, but clinically, this is highly relevant because every single millimeter that we can shrink in this area leads to a better closing surgery. So we're happy with these results. Our second topic, or second figure, is a bit different because here we're, as you can imagine, the babies are growing, the maxillas are growing, therefore the cleft obviously will grow, but we're also trying to tackle the fact that we want to shrink this area. So we're looking for either no change or a slight shrinkage that we're looking for. Here we could use 4 RCTs with a slightly smaller amount of babies. Heterogeneity went lower as well. And when we looked into our 2 groups, you can see that we could still see a slight shrinkage through that area towards the PNOM group, which is clinically relevant, but also indicates that we do need more research on this area as well. When we go into our very last figure, you can see that here we were actually even anticipating less growth because this area is the one that we're hoping to grow the most as a normal healthy baby would grow out throughout this period. So as we can see here as well, we use 4 RCTs with a small heterogeneity number, and when we compare the 2 groups, you can see that there's also a slight shrinkage as well, which favored the PNOM group. Luckily, we all could use blind randomization project with relatively large sample sizes, but our limitations were that these studies use different infant protocols, as well as we don't have many articles to look into, and therefore we had quite a high heterogeneity number with it. Looking at our results, we can see that PNOM is more efficient than no PNOM treatment in UCLP in the anterior cleft region. Therefore, we think it should be used in a periodic treatment, and that we can see that it actually shrinks the cleft, and it should be integrated into everyday care in all different facilities and hospitals. And for research, it is important to see that posterior arch width and the canine region width should be explored a bit further, and we'll also need a guideline because we don't have a guideline at this moment. We're done with the manuscript writing and hoping to get into interviews soon. Up until now, I talked about the therapy possibilities, but it is also very important not just know the treatment ways, but also know the whys of how it happened. Therefore, we wanted to look into the seasonality of birth month of patients born with orofacial cleft between 2014 and 2024 in Hungary. And this would be a retrospective case control study. We talked about the background before. It is very multifactorial, and we know some of the environmental factors when it comes to drugs, alcohol, and smoking, but little do we know about the actual environmental factors that comes with any kind of different area, and a lot of the studies actually give us conflicting conclusions. As you can see, it is a highly relevant study because, as you can see, even in different continents and countries, they're already looking into whether it has a seasonality or not. Luckily, in Hungary, we have a registry that is available for us with the following data. And from that, we can actually pull all the results that we need to see whether they have any seasonality in the past 10 years or not. From this database, an article has already been written and submitted, which is basically shows us that not just it's not orofacial itself, but it's more congenital anomalies, that you can see that there is a very specific seasonality. And by learning that, we can easily figure out whether we should research more of the different environmental factors or not. This leads me to my clinical question, which is there a monthly birth rate pattern in patients born with orofacial cleft? Our populations were babies born with cleft. Our exposure per month, and we were looking into different birth rates of these months. Our hypothesis is that there is a seasonality in birth if we're born with orofacial cleft, and our clinical and research implication would be finding seasonality in orofacial cleft can give us solid basis for further research of etiology factors. So as to sum up my goals and my project up until now, working closely with these children in everyday work, I think it's a very demanding anomaly, both for parents and for children. And I think we should help them in any ways we can by researching either the origin or the therapy possibilities to help them however we can. And I'd like to thank you for your attention with a quote from Stephen Hawking: "The greatest enemy of knowledge is not ignorance, it is the illusion of knowledge." Thank you very much.
I was thinking about the impressions were made with intraoral scanners, but actually they aren't. We could see in the picture. So could you explain how these impressions are taken for the babies?
Thank you for your question, Bruna. That's a great question. We love to go into a more digital way in the future and do an oral scan for this, but for now what we have available is we have these especially made little basically acrylic ways that we put in with the molding itself, and we're really happy because obviously there's like one day old to 2 weeks old when we start the impressions, so we want to see is that they cry. I know it sounds funny, but when they cry they open their mouths. It's way easier for us, and we also know they're breathing, because you know if the impression material gets into the nasal way, which is really easy because of the open gap, or into the mouth area, they can obviously very easily suffocate. So this is a very highly risky procedure, but the end goal, it helps us out, so we're taking it manually for the moment.
Sorry, do you have like little moldings for that?
Yeah, we do. Yeah,
okay.
Especially made, and it's obviously each acrylic plate is made individually, and from those we can go back prior time and make actual spoons with them, so we still can improve our pool that we can choose different spoons from for the babies.
The material is silicone, I think.
No, that would be way too. It has to be as fast as possible. So we use alginate, but we also use the one that we use for orthodontists, which like cures in like under a minute. So it has to be super fast.
You showed for the seasonality a number of papers.
Yeah.
So what did they find? What is it due to have a seasonality change, or did they have any change?
Thank you for your question. Some of them find that, for instance, they have a higher birth weight in January, and then we can go count back what they didn't explore further what could have happened. It was just clearly just to see what's the most common birth month of these babies. But what we want to take out of that is whether we can count back all the months, and the first 3 months it would be the critical area, and then we can look back onto that. So they were only just looking into, is it January, is it February, and what can we take from that?
Mm-hmm. So they didn't bring up any etiological reason for those changes that they have seen?
They were either debating, was it vitamin D, is it like the environment, is it the sunshine, is it there's so many different areas to go into, which would be a whole other study, I guess, so we want to find a solid base. They didn't look into that, just like had some theories about it too.
Okay. Do they do some kind of Fourier analysis or something like that to measure the seasonality, so it is by day, by month, or so there are some specific analyses like Fourier analysis to capture that, not just looking by eyes, but really mathematically capture that what is the number, what is the scale of the...
I think for the studies, I can't say too much, but for our studies, we're not in that phase yet to evaluate which one to use yet, so when we get there, I'll happy to answer this question.
And I have some question for the first study, because you are writing article that, can you go back to the first figure? Because you said that, I'm just wondering that if I understood correctly, that you said that it's clinical relevant 5 millimeter, but you said statistically it's not significant, but I saw significance based on the confidence interval. It didn't reach the 0 value, it's 0.4.
They told me it wasn't significant.
It's significant.
Okay, then it is significant. Great.
I don't know.
I've been told it wasn't.
Based on the confidence interval, if it doesn't reach the 0, it should. It reaches. It's 0.4. Yeah, it's plus. Okay, it's minus. Okay, sorry. That was okay.
So
that's
it's not
correct.
significant.
And another thing that the other 2 parameter was not significant, and I'm just wondering because this is a 3-dimensional anatomical structure, and they are measuring linear distance. This is a common failure in even in the intraoral scanner studies, that somebody want to measure a 3-dimensional structure in linear distance, and especially so it can be moved, it can be rotated, and that's why maybe the linear distance is just it's a cover. You cannot reveal the real differences because of the linear distance measurement on a 3D movement.
Right.
So that's just maybe something which you can add it to the discussion section.
Okay, thank you very much.
Especially because there is a large distance.
Right.
So you measure almost significant value in the small distance, which is more specific, but larger the distance, you have more chance that you fail to reveal the real differences.
Okay, great. Thank you so much for this view.